Well, first, I'd like to thank the organizers of CanMed for so graciously and generously inviting me to once again be part of their annual conference. CanMed is one of my absolute favorite conferences, and I'm so sorry not to be able to join you in person this year. But with that, I will talk about what's in your weed, assessing the impact of individual cannabinoids on clinical outcome measures. Now, as I don't really have to explain to this audience, cannabis has been part of ancient civilizations with references to its use spanning thousands and thousands of years. In fact, it was part of our US pharmacopoeia. In 1850, doctors could and did prescribe cannabis. It wasn't a recommendation for use or a certification for use, it was a prescription for any number of indications or conditions or symptoms that patients had. Through a series of events, it fell out of favor in 1937, and by 1942 was pulled from the U.S. Pharmacopoeia, and in 1970 it was placed in the most restrictive class of the newly created Controlled Substance Act. It was classified as a Schedule I substance, where it remains today, Schedule I substance. Since 1970, when cannabis was declared a Schedule I substance, California was the very first state to re-legalize cannabis for medical purposes in 1996. 1996. I make this point because by the time my own state had legalized cannabis for medical purposes, and you can see in that timeline how different states sort of followed California's lead. But by the time Massachusetts legalized cannabis for medical purposes in 2012, there was still absolutely nothing in the literature with regard to what I would call the long-term or longitudinal impact of medical cannabis. That surprised me. Pretty much everything we know about cannabis comes from studies of young, primarily healthy, recreational cannabis consumers. In fact, my lab has been studying the impact of recreational cannabis use for decades at that time. And I was quite interested in understanding the potential differences in those using for recreational versus medical purposes. So I scoured the literature, figuring there had to be something. And I did find some studies of acute administration of some products for medical purposes, but nothing that looked at patients or subjects pre versus post, nothing that classified or characterized cognitive performance or really even clinical change as a primary outcome, and nothing that followed patients over time, nothing at all. So in 2014, I established the Marijuana Investigations for Neuroscientific Discovery program, or the MIND program at McLean Hospital. So this is really the first program of its kind, and it's dedicated to looking at the long-term impact of medical cannabis use on things like clinical state, cognitive performance, sleep, quality of life, conventional medication use, where applicable, measures of brain structure and function, and related measures, pretty much anything we can think of, right? The program uses longitudinal, observational, cross-sectional survey, and clinical trial models, and it supports projects designed to examine custom-formulated novel cannabinoid-based therapies for a range of symptoms and conditions. We examine major and minor cannabinoids and their impact on clinical and cognitive outcomes. And the ultimate goal here really is to be able to harness therapeutic potential while minimizing risk and harm related to medical cannabis use. So our very first longitudinal observational study, again, longitudinal observational study, not a clinical trial, observational study, was designed to actually set the stage for other types of studies. But this study really looked at clinical state, cognitive performance, mood, sleep, conventional medication use, all those things I just mentioned to you, in individuals who were interested in using medical cannabis before they began their treatment regimen. This is a very important point. So here are folks with various and sundry indications and conditions who are interested in exploring medical cannabis use for whatever indication or condition they'd like, but we see them before they begin using. Okay? We then follow them. Initially, we had very ambitious goals of going out to almost 1 full year, which we thought was a lofty goal. We have now extended that several times. We now follow patients out to 3 years because generally once they're enrolled, they don't want to stop, which is wonderful. So we see them for a baseline visit before they begin using. And we see them again at months 3, 6, 12, 15, 18, 24, and now 30 and 36. We also talk to them every month with regard to their medical cannabis use and other things. They can use medical cannabis for any indication or condition that they'd like, pain, sleep, mood, anything, and their choice of products. Those products are ultimately assessed by an outside laboratory. More on that in a moment. The assessments that they complete at each of the time points, those what I call the milestone study visits. So again, baseline 3 months, 6, 12, etc. They consist of things like clinical ratings, where we're looking at pain, mood, anxiety, sleep, quality of life, and anything else I can think of. Very detailed information regarding their medical cannabis use. So, really detailed, fine grained information, individual level data on the actual products they're using, product type, frequency, amount, source, cannabinoid constituent profile, etc. Conventional medication use, because we're looking at potential change over time, measures of cognitive performance, and of course, when we can, a multimodal neuroimaging protocol that allows me to look at their brain structure and function and all sorts of other things. So it's a pretty comprehensive longitudinal observational study. In order to be considered eligible for this study, people have to be over the age of 21 and have a valid certification for medical cannabis use or plan to use products that don't require certification. This whole landscape has shifted slightly since the legalization for adult or recreational use. But back to the certifications, they can be for a range of indications. As I mentioned, we didn't limit this first study to any specific individual clinical cohort. We weren't sure how many people we would get. They have to be cannabis naive or have no regular consistent use of cannabis over the past several years, and they have to be negative for THC at baseline. We also had a group of control patients. So these are individuals who have similar conditions and indications as our medical cannabis cohort, but who are not interested in using medical cannabis. At least when they sign up, they're not. We've lost several people in the treatment as usual group to the actual treatment group over time, not surprisingly. So in 2016, we published our first paper. I was asked by a journal to get at least 10 patients from baseline to their first longitudinal assessment, which was 3 months. I think we published on 11. Again, we looked at these folks before they began using medical cannabis and 3 months after they had been using. And what we found was really quite striking. We found improvements on some measures of executive function and clinical state, and a reduction in their use of conventional medication use. The reason that these findings were so important, at least in my mind, was that, again, we had spent decades looking at the impact of recreational cannabis use on cognitive performance and clinical measures and measures of brain structure and function. And generally, our work and the work of colleagues across the country and throughout the globe had suggested that individuals, especially those who began using early on in the developmental trajectory, when the brain is still vulnerable, had decrements in certain aspects of cognitive performance, for example, measures of executive function. We didn't necessarily see those same patterns of people who began using later, a very important distinction. But so here's this first study of medical cannabis patients over the course of 3 months showing no decrements in cognitive performance, but improvements. So we expanded that study and actually ultimately, and I should say that that first study got a ton of media attention, and I think it was in the top 5% of all the studies referenced in Altmetric. We published, I think, in 2021 on a cohort that we followed over the course of 1 year. This was 54 patients followed over the course of a year, again, before they began, and then at 3, 6, and 12 months. And once again, what we found were significant improvements on some measures of executive function and clinical state over the course of their 12 months of treatment. We also found that measures of verbal learning and memory generally remained stable, so no decrements. First and foremost, what we see in these studies is no decrements in cognitive performance or clinical state, but improvements. Very, very important. So this study has continued, and now I'm going to show you data from a larger sample. So this is a data set of 67 medical cannabis patients who completed a baseline and at least one follow-up study. And you can see on the left-hand side of the screen that these folks are about 46 years of age. So let's just say beyond the period of neurodevelopmental vulnerability. These are not kids or emerging adults, right? They're predominantly Caucasian. They have a higher than average IQ at almost 120. And they're well educated, 16.54 years of education. As a reminder, 16 years of education is analogous to a college degree. Duration of cannabis abstinence. So they've been abstinent from cannabis use on average for 20.3 years. That makes sense, since most of the time, if these folks have had any history of cannabis use, it's a remote history of use in high school or college. What are they using cannabis for? What are they interested in using cannabis for when they first enroll? Well, the top 3 indications really echo what we see across this country. The top 3 spots in this country, and really every state, generally fall between pain or anxiety as numbers 1 and 2, and then sleep. So in this cohort, it's anxiety, PTSD, then pain, then sleep. Then there's mood and attention and other. What's other? Inflammatory bowel disease, chronic migraine, headache. As I mentioned, we also have a pilot group of treatment as usual patients with similar conditions, but who are not using cannabis. So we also looked at those folks over time. In terms of some of the assessments they get, these are self-report rating scales in terms of looking at mood, anxiety, sleep, pain, and quality of life. And I wanted to just highlight what some of these are. They're the profile of mood state, a really, really common measure. All of these are very, very common, well-validated measures. Here we're looking at total mood disturbance. We also do the Beck Depression Inventory, a very common measure of depressive symptoms. For anxiety, we have the Beck Anxiety Inventory and the State Trait Anxiety Inventory, again, classic. For sleep, our primary outcome measure is Pittsburgh Sleep Quality Index, or the PSQI. For pain, we're looking at the Numeric Rating Scale, the Pain Distress Scale, and the Pain Disability Index. And for quality of life, I'm going to show you data on the WHO. Again, this is a subset of what's actually administered. So first, taking a look at our cohort over the course of 1 year in terms of mood. What we see, again, total mood disturbance of the profile of mood state is on the left, and the Beck Depression Inventory is on the right. But overwhelmingly, what we see is that patients report significant improvements in mood-related symptoms between 3 and 12 months after initiating medical cannabis treatment. The green line is our medical cannabis patients. The blue line is our treatment as usual folks. And what you see is a statistically significant improvement at each time point for the MC patients. We do not see this change in treatment as usual patients. Okay, that's true for the TMD and the BDI. We turn to anxiety, which is a very special area of focus and interest in my group. Once again, we have the Beck Anxiety Inventory on the left and the trait scale of the STAI on the right. Patients, once again, report statistically significant improvements in symptoms of anxiety between baseline, 3, 6, and 12 months of treatment. The treatment as usual, folks, those folks on the blue line, that's the blue line there, do not demonstrate the same pattern. No improvement. Looking at sleep, patients are generally reporting improved sleep quality between 3 and 12 months after initiating medical cannabis use, a statistically significant improvement at each of the time points in the medical cannabis patient group. We do not see the same in the treatment as usual group. In a subset of patients, these are folks who are using medical cannabis exclusively for chronic pain conditions. What we see here is over the course of 3 to 6 months, patients with chronic pain report significantly decreased ratings of pain on the Numeric Rating Scale, the Pain Distress Scale, and the Pain Disability Index across the board here. Okay, again, the green line is the patients, blue are the treatment as usual folks. Statistically significant improvements over the course of a year in the MC patients that we don't see in the treatment as usual folks. Are you sensing a theme? Because I am. Finally, with regard to quality of life, and this is the WHO qual, physical health on the left and psychological health on the right, what we see are significant improvements on some aspects of quality of life, specifically here for physical and psychological health. We actually didn't see any change in social relationships or the environment subscale scores. Those remain pretty stable over time. But for psychological and physical health, we do see a statistically significant improvement over the course of 1 year of medical cannabis treatment in the patient group, not in the treatment as usual group. So, pretty interesting. I think it's fantastic to see that overall people are getting better, but it certainly raises the question, what's in your weed? What might account for the improvement, and how can we find out what's in your weed? How do we best do this? Once again, I turned back to my extraordinary lab, and we were able to create a step-by-step metric that really quantifies estimated maximum possible cannabinoid exposure. It's called CannaCount, and it's an improved metric for quantifying estimates of cannabinoid exposure. The increasing array of cannabinoid-based products contain various amounts of different cannabinoids and other constituents. Existing methods are pretty limited, though, and none at all account for actual cannabinoid content of the products that patients or consumers are actually using. So we created something. This metric basically considers things like the actual individual cannabinoid constituents, frequency and duration of use, the amount used, and the route of administration or mode of use. All of these things are incredibly important in figuring out, quote, what's in your weed and what might people be exposed to over time. So this is just a slide showing cannabinoid constituent information and how you get it. On the right side, what you see is a laboratory analysis that breaks down, again, a cannabinoid constituent profile, how much of each of the constituents is found. Medical cannabis product samples are basically sent to a third-party lab for this kind of profiling. Again, it quantifies the amount of individual cannabinoids. If actual product samples are not available for testing, or if patients are unwilling to part with even a tiny amount for testing, which so far has not been a problem, thank goodness, you can rely on dispensary or supplier certificates of analysis if you have to. And also, you can use product labels. Not preferred given the very known and very obvious issues with product labeling accuracy. So, what you really want is to get a sample of the actual products that patients are using and have an outside lab analyze. That's how we did it. So, as an overview of CannaCount, and I won't belabor this too much, you can pull the paper. It's really, really helpful step-by-step guide. But basically, we're querying patients, and you can use this with recreational consumers as well for people who are interested in figuring it out. You're asking questions about product type, frequency, amount or magnitude use, and duration of use. And again, then we get this laboratory assessment. We organize the data and then convert the data into what I would call preferred units for the calculations. So we might convert, for example, things like percentage to milligrams per gram or milliliters to gram. We also account for conversion of the acid form to the active form, right? That's really, really important. And we calculate exposure generally in two ways. You can use one or both of these. One is the discrete use approach. So patients report frequency and amount of the products used each time. So how much and how often they're using each individual product. Or they can report the total amount of a product used over a period of time. So, for example, I might say to a patient, so you bought 3.5 grams of X flour. How long did it take for you to go through that? How did you use it, etc. So those are just some examples. CannaCount, this metric, can actually be used to estimate exposure to any cannabinoid, not just THC and CBD, which most people spend a ton of time on, but the minors as well, as long as the cannabinoid content is known and derived from what I would call a reliable source. That's really, really important. This is just a quick slide that shows you how you calculate exposure for the discrete use approach versus the total use approach. But this is all detailed in the publication. And all of this is just a way of getting to what I want to show you, which is the what's in your weed factor. But again, you can actually sum cannabinoid exposure for each route of administration. So for example, you have folks who are using routes of inhalation. They're smoking and they're vaping. You can sum those. You can also sum, for example, anything that was an oral administration or a mucosal or a skin-based product. Some have asked us whether they can sum exposure across product types. You certainly can. I don't necessarily recommend it because it doesn't account for different bioavailability across product type and route of administration. We all know that, right? The ways in which we use these products and individual product types are not all created equally. But back to our own sample of patients. So this is a bar graph that basically illustrates exposure to delta-9 THC and cannabidiol or CBD at 3 months and at 6 months. And what you see, so THC is the dark green and CBD is the minty green. What you see immediately is that between baseline and 3 and baseline and 6 months, our patients are being exposed to significantly more CBD than THC. This is perhaps not surprising because generally our patients are very clear on not wanting to be high or altered. In fact, what they say is, Dr. Gruber, I don't want to be messed up. I can't sort of be checked out during the day. I have a job to do. I just want to be able to sleep through the night. Or I just want to be able to take a walk with my husband or remember my kid's birthday or something. That's what they tell you. They're not looking to be high. So very often they're choosing products that have an array of non-intoxicating cannabinoids, very often rich in CBD. So to examine the unique contributions of THC and CBD, we actually conducted and examined correlations between these cannabinoids and outcome variables, so clinical measures. And here's what we found. Relative to baseline, following 3 months of medical cannabis treatment, higher THC exposure was actually related to improvements in pain severity, as measured on the visual analog scale and the numeric rating scale, and pain-related distress. You can see that in these graphs, right? So higher THC exposure and greater improvement. We didn't see any relationship between higher THC exposure and mood or anxiety measures. So what happens at 6 months? Relative to baseline, at 6 months of medical cannabis treatment, THC exposure is no longer related to any measure of pain or mood or anxiety. So we saw it at 3 months. We didn't see it at 6 months. Really, really interesting, especially when we consider what's coming next. With regard to CBD or cannabidiol, relative to baseline, after 3 months of medical cannabis treatment, higher CBD exposure was actually related to improvements in mood, We see this in the PALMS total mood disturbance score, the Beck depression inventory, and anxiety measures, so both the trait and the state measures. We also see it in terms of improvement on disability caused by pain, so the pain disability index. Very, very important. That's 3 months of treatment. At 6 months of treatment, now what we see is higher CBD exposure continues to be associated with all of those measures. So we have the total mood disturbance and BDI and the anxiety and PDI scores. Higher CBD, greater improvement on all of those measures. And now we also have an association with improvements in pain severity as measured by the numeric rating scale and pain-related distress. So at 6 months, we see the same improvements with CBD on mood and anxiety and pain distress. And now we're seeing pain severity and pain distress also improving with CBD. Very, very interesting. As I probably don't have to explain to this audience, given some of our esteemed folks in the audience, I'm sure, minor cannabinoids often exert a major impact. And although we need more work in this area, we certainly have a fair amount of evidence suggesting that some of the so-called minor cannabinoids, termed only minor because of the amount in which they are present in chemobars, they can have a major therapeutic effect. So, for example, cannabigerol or CBG has been shown to exhibit anti-tumor, antioxidant, and anti-inflammatory properties, and is often touted as being neurogenic. Cannabichromene or CBC, hypothesized to have anti-inflammatory, antibacterial, and antifungal effects, and also shown to increase viability of adult neural stem progenitor cells. THCV, or tetrahydrocannabivarin, shown to inhibit some of the negative cognitive and physiologic effects related to THC administration, and may also be neuroprotective. And that's just the beginning. So much more. So the question is, what about the minors? Well, when we looked at the minor cannabinoid exposure in our population, what we see is certainly a range across the board with CBG and the acid form, CBN, CBC, and THCV. But it raises the question of what's in their weed, what's in the product. So we did an analysis of all the products submitted by our patients to look at the presence of minors. And what we found, this is all of the cannabinoids, let me be clear, not just the minors. This is everything, and I'm going to pull out the minors. So first and foremost, when we consider all of the constituents, 82% of the products submitted had detectable CBD. Almost 71% had detectable delta-9. And really right after that, the next step, cannabigerol or CBG at 58.8% and cannabichromene, CBC, at 54.9%. So well over 50% for those two. After that, you have the acid form of CBD, you have CBN or cannabinol, THCV, etc. So very, very interesting, right, in terms of what's in these products. So in more than 50% of the samples, we found CBG and CBC. So we conducted preliminary analyses to look at the potential relationship between these two cannabinoids and any potential change in clinical outcome. What domains are we looking at? Once again, pain, mood, and anxiety. And here's what we found. Increased exposure to CBG and CBC were both associated with lower distress related to pain. If you look on the left, that's CBG and the pain distress scale on the left-hand side, significant. And on the right-hand side, that's CBC and the pain distress scale. So really, really interesting, right? We're not necessarily seeing relationships between CBG and CBC and actual mood and anxiety measures. In fact, we didn't. We looked again. There's no relationships that we found in this preliminary analysis between CBG or CBC and any specific mood or anxiety measure. Instead, we're seeing lower distress related to pain. So let me summarize what we see so far. In a longitudinal observational sample of medical cannabis patients, the clinical data are clearly showing areas of significant improvement between 3 and 12 months of treatment after initiating their medical cannabis regimen. We're seeing improvements in measures of mood, anxiety, sleep, pain, and quality of life. Their treatment regimens contain vastly greater amounts of CBD relative to THC. We get that by using this great metric, CannaCount, and actually quantifying exposure to individual cannabinoids over time. We're not guessing, we're not taking their word for it, we're actually quantifying it. Accurate estimates of cannabinoid exposure using CannaCount or this metric will help clarify the impact of cannabinoids on treatment outcomes and hopefully generate more accurate risk-benefit ratios. We're desperately in need of it. We need something to help us. We also saw improvements related to THC and CBD exposure that were very different. When we considered pain, we saw reductions in pain associated with higher THC exposure at 3 months, but we did not see that same relationship at 6 months, only at 3 months. Most associations between pain and CBD exposure were noted at 6 months. And with regard to CBD, we did see improvements in anxiety and mood with higher CBD exposure at both 3 and 6 months. That seems pretty consistent. So, very different responses to these two primary cannabinoids when we think about them, right? Before we get to the minors. When we consider the minors, we saw that the products that are being used by our patients do contain a range of minor cannabinoids. More than 50% of all products analyzed contained CBG or CBC. We did see significant relationships between the minor cannabinoids and measures of pain. Specifically for CBG and CBC exposure, we saw a significant association with reduced pain-related distress. Pain-related distress. So clearly, we need additional studies that look at specific relationships between the so-called minor cannabinoids and the major clinical impact they may have, and what subtle nuances they may actually confer. So again, pain-related distress is not necessarily the same as pain reduction. So really, really interesting and important area of investigation. So next up, I just want to touch on mindful activities and the fact that we do a lot of custom formulation. We're currently conceptualizing and formulating a number of additional cannabinoid blends optimized to treat various conditions and indications. These are whole plant derived full and broad spectrum products, hemp and cannabis based. And basically it creates steady products that are high in cannabinoids that are typically considered minor, but which demonstrate tremendous clinical potential in some cases. This is for some of these studies. We're interested in examining the impact of terpenoids on a number of biobehavioral measures as well. Terpenes, of course, are the essential oils that give cannabis its characteristic scent and flavor profile. Neither THC nor CBD have a scent or flavor. That's the terpenoids. They themselves have their own biobehavioral health effects, and I'm actually currently optimizing some terpenes to ultimately address specific indications and conditions, which are really exciting. So we have a number of clinical trials designed to assess efficacy and safety of custom formulated full and broad spectrum products, and a number of INDs or investigational new drug approvals in hand. I'm very, very excited. We're looking at moderate to severe anxiety in a number of cohorts, anxiety and agitation in Alzheimer's-related dementia, mood and anxiety in patients with bipolar disorder, that's kicking off this month, anxiety and pain in patients with glioblastoma, with a very exciting exploratory aim of potentially slowing tumor growth. And of course, we now have a new study focused on chronic pain, and that's actually taken a fair amount of work in terms of optimizing some of these lesser-known cannabinoids or terpenoids. In addition to considering THC and CBD content, again, we're optimizing products with regard to the minors and their terpenoid content. So I would conclude by saying we have an unprecedented opportunity to customize and optimize cannabinoid-based treatments for our patients, which has the potential to transform patient care and medicine as we know it. By harnessing therapeutic benefits of cannabis while also mitigating potential risk and harm, cannabinoid-based treatments may very well be the answer for countless individuals for whom conventional medication doesn't provide adequate symptom relief or produces unwanted side effects. Both of those things, unfortunately, result in lower rates of compliance in our clinical cohorts. So we have to do something, right? And with this, I would thank you for your time and tell you that I couldn't do any of this work without my extraordinary team, as well as my very esteemed collaborators, and tell you that if you have any questions, I'd be delighted to answer them. Contact me at gruber@mclean.harvard.edu. You can also check us out at themindprogram.com. Lots of exciting things, so much to be excited about. Have an amazing, amazing rest of your conference. Again, CanMed is an extraordinary experience, and I wish you all the very best. Stay safe.